Bringing Patients Back to the Center, Kūpuna Stories, and the Need for Advocacy. This session will be divided into two parts. For the first part of this session, we'll be sharing videos with you from Kula, Hawai'i, which is a local community-based organization here in Honolulu. We're really fortunate to be able to bring these stories to you today in collaboration with them. We'll first learn about the amazing work that Kula has done throughout the pandemic and over the last several years. And then we'll hear some stories from Kupunas and caregivers who participate in the Kula Care Coordination Network on what matters to them as they age and what matters to them, to the people that they really love. So let's please direct our attention to the screen, and I'm going to share the video and the stories.
Nonprofit serving the Papakolea, Kewalo, and Kalawahine Hawaiian homesteads for almost 30 years. Created by Community Kupuna, Kula's mission is to provide education, health, and cultural programs and events to support and enhance the lives of homestead residents.
Executive Director Dr. Adrian Dillard and Associate Director Puni Kekauoha lead a staff of 15 to provide services and resources that address the holistic needs of our community from keiki to kupuna. Out of 17, our staff, the Kula crew, includes 11 homestead residents, 5 social workers, 8 community health workers, and 2 kane. As we fondly say at Kula, we the women.
Kula's educational programs include the Lamaku and Junior Leader After School program, which provides a safe space for community keiki to receive homework assistance and cultural education. Retired fire captains support local residents through the Honolulu Fire Department application process in the Papakolea Fire Academy. Since 2010, this program has trained over 800 men and women, with a notable number gaining employment in county and federal firefighter departments.
Na Lomi Lomi o Papakolea provides traditional healing to community free of charge. A legacy of the late Somerset Kalama Makaneole and his vision of sharing his ohana style of kinoho'oponopono, or total body alignment. The Kupuna Community Care Network is a one-stop shop for Papakolea Kupuna and their caregivers for increased access to information and services. The goal of KCCN is to empower families to support their kupuna to safely age in place.
During the COVID-19 shutdown, all programs were either moved to an online format or temporarily closed. Kupuna wellness phone calls, Lamaku YouTube activity videos, and Zoom workshops are a few examples of how Kula programs continue to engage and serve participants. Annual community events were also adjusted to allow COVID guidelines and restrictions. High school graduation, Halloween, and Christmas events were all carefully planned to allow families safe and responsible celebrations.
When Governor Ige officially closed all schools and non-essential businesses in March of 2020, Kula made an intentional choice to enter the realm of pandemic response. This presented new challenges and community issues we've never addressed before. The 3 main concerns during the pandemic were food security, public health, and community safety.
The first need we encountered was food security. This quickly became a priority as more families lost income and the stay-at-home orders went into effect. Beginning in April 2020, Malama Meals provided 100 lunches and 800 dinner plates daily. Soon after, other organizations and partners asked how they could provide continued and additional support. Kupuna and Keiki received hot lunches and meal sets prepared by Malama Meals, Lunalila Homes, and Lanakila Meals on Wheels. Ultra Staffing sponsored healthy grocery boxes and meal sets. Chef Hui, Ham's Produce, and Y Fukunaga Products continue to provide these to Papakolea families through May 2021. Donna Kahakui, an avid paddler who was raised in Papakolea, returned to coordinate 2 food drives supported by the Oahu paddling community and Punahou School. All of these sponsors and organizations partnered with Kula to provide 80,023 meals and 14,780 food boxes and meal sets.
For me, it's a blessing to be able to stand among the younger people and work side by side. And people come down, and you load their cards, and when they tell you thank you, God bless you, that's all you need to hear. It makes it all worthwhile. I hope the members of the community get benefited by what programs Kula offered. Remember that. Pass that on to your children, your grandchildren.
We at Kula cannot express the full extent of our gratitude to the funders, partner organizations, businesses, and volunteers that fed our communities during this time. Their support and commitment to service kept our families and loved ones safe and healthy. Mahaloa nui. We would also like to send a very special mahalo to the community residents who joined our journey to serve and became a part of the Kula crew. We truly appreciate each and every one of you.
I stand amazed and ever so thankful to all of you for standing strong and being there when we needed you and when we needed each other, and making a collectively, corporately, making a huge mark and impact on this community, and it will forever be remembered.
As we address the need for food, opportunities to protect and promote the health of community residents, especially Kupuna, came forward. 3 COVID testings were held in partnership with Kalihi Kai Urgent Care and served 241 residents. Keola Mamo provided a flu shot clinic serving 68. When COVID vaccinations became available, Kula staff member Kathy Solatorio quickly brought vaccinations into the community. Through her efforts and multiple clinics with Kaiser Permanente, 354 people received 703 vaccine doses so far.
The pandemic also highlighted the importance of knowing and understanding our communities. In 2015, Kula conducted its first homestead health survey in Papakolea. The goal of this survey is to better understand the unique characteristics and issues related to the health and well-being of homesteaders. Since then, we have surveyed Kailapa and Napua Ka'ilima in 2017, Halemakana o Nanakuli in 2019, and Malu'ohai, Kaupea, Kanehili, and Kauluo Kahai in 2020. We are currently surveying Wai'anae Valley. The findings of this survey are intended to guide homesteads in their future quests for resources and services that will benefit their community.
Kula leaders were invited to participate on the NHPI Hawaii COVID-19 Response Recovery and Resilience Committee and National COVID-19 Resilience Network with Morehouse School of Medicine. These discussions allowed Kula to stay connected, informed, and provide input at the national and local levels.
As the pandemic continued, the impacts of COVID-19 heightened existing community safety concerns. One example of this was the increased number of homeless individuals staying within community. Even as some disagreed, Kula rallied to support these individuals because majority of them are from community families. Since January, we have assisted over 30 people with homeless services.
Papakolea and surrounding communities experienced a rising number of safety and security issues, such as people casing streets and homes, burglarizing property, stripping stolen cars, street fighting, and illegal game rooms. Kula launched a culturally tailored safety campaign, E Ho'omau Ka Ko I Kamaluhia I Papakolea, to raise awareness about protecting our homes and loved ones. The future looks bright and busy for the staff of Kula Nanopo'e Hawaii. Exciting tasks ahead include reopening Kula programs in person, Kupuna advanced care planning, multidisciplinary practicum teams to assist community families, homestead beneficiary workshops, and Ike Kupuna Ola Ho, a hula program for Kupuna to stay active physically and mentally. Kula will also be assisting Kapolei homesteads to address the findings of their homestead health survey through training and capacity building.
As we reflect on the past year, we realize we're the busiest we've ever been. We've connected and served the most families we ever have in our 30-year history and earned something all organizations strive for: trust. From this trust, the motto, Papakolea Strong, represented the collective commitment to keep this community safe and healthy. Through one of the most difficult years of our time, Papakolea became kinder neighbors, greater friends, and a stronger community. It has been Kula's privilege to answer the call and lead the pandemic response for Papakolea, Kevalo, and Kalabahine.
Oh, yeah, I just wanted to thank Adrian and Puni.
Much mahalo, Kula. I love you folks, man. Mahalo so much.
Aloha and thank you, Kula.
Mahalo. Mahalo, Kula.
Kula no Napo'e Hawai'i strives to perpetuate the vision set forth by Prince Jonah Kuhio Kalaniana Ole. In honor of the 100th anniversary of the Hawaiian Homestead Act, our journey shares the strength and resilience of the Kanaka Hawai'i. As we look towards a promising future, we thank our supporters and community for standing Papakolea strong. Me ke aloha, the Kula crew.
It's like aloha kakahiaka. Good morning.
Ako, my name is Cappy Anuenui Shea Solitario. I was born in Papakolea. I live here all my life, and I have my husband is Samuel Solitario. He's from Molokai, and I have 4 children, 3 boys and 1 girl, and they're all adults and all working. I have my background in fashion merchandising at the University of Hawaii. I got my bachelor's in fashion merchandising and interior designing. And when I adopted my first boy and my second son was born, I decided to do daycare. And I worked there at my home for 30 years doing daycare because I wanted to be home with my children and still be able to make an income, because my husband said, you can't just fry chicken, right? So I said, okay, I am going to do daycare. So I got my license with the state and I did daycare. And I later on met Dr. Adrian Dillard and did some outreach work for her, and then worked for her for full time as research assistant, doing different projects on diabetes, hypertension, with the Department of Native Hawaiian Health. And I've been working there, with this company for quite a while. I left for a little while and then I came back, and now I work at Lincoln Elementary School as a community health worker there. So I work in the office, I do all kinds of stuff with the children, and I just love it. I do part-time caregiving for my dad. He's 92 years old, in good shape, but I try to juggle my schedule where I can still help my dad, take care of my husband and my family, work at Lincoln, come up to the park. Yeah, I'm just Miss Aloha.
I'm Charlotte Kumaeva. I live here in Papakolea with my husband, who is also a lessee, and his name is Terry Kumaeva. We also have 2 grandsons who are adults now that have been staying with us over, I would say, maybe 10 years now.
My name is John Saito Jr. I grew up on the very top of this mountain on Ka'ula'au Street, and I resided down below for 25 years. I met and married my wife, and she had four sons from her first marriage, and then we have a daughter together. When she passed in 2018, I decided to move back home with my parents. Well, it wasn't a decision, it was a no-brainer. It was time to come back home. And at that time, my parents aging, and in 2017, my wife had 2 brain seizures at the airport. When we got to the hospital, they said her numbers were so crazy that she should have died there. But God allowed us to have 1 more year, and all the procedures went as planned. It's just that her organs didn't kick back in, and it was God's decision to take her. And if I wasn't okay with His decision, then I wouldn't be okay today. And then that's when it was time to come home and face the challenges with my parents. And my dad was diagnosed with dementia, which, hey, I walked to the front of the house, I forget what I came, it's a process that some of us are going to go through. But I thank God for Kula, who provided classes for us here. And it helped me prepare for the abrasiveness, the impulsiveness, and all those things that come with aging, And could I have done it better? Yeah, probably. Yeah. I think I did okay. Yeah. And not by myself. I have 6 sisters, 1 deceased, and it's a process. Trying to work with different personalities and help mom and dad through this process. And eventually, my dad had a heart attack, and we had some time with him, and he passed at home in October of last year. Mom's currently 91 and very active, and I wouldn't change anything. Yeah.
Issues come up in our health life, and so eating better foods like fish, vegetables, fruits, whatever we can even actually get off the aina is even better yet, because whatever's in the aina gives us back our health also. And also walking is something that I had finally decided once my husband and I retired. I said we need to start walking because I'm pre-diabetic, and we both have high blood pressure. So I said we need to get back to walking. So we go down to Ala Moana Center and we walk. We started off like maybe 2 levels. Doctor says start off with just 15 minutes, and we started with 15, and before you know it, we're going into 20 and closer to almost a half an hour. So we did all the levels without shopping. But yeah, so anyway, that part also is just the exercising. I do hula, that's part of my passion is hula. So besides the walking, the hula is another part that I feel very strong about. And then also to keep my blood levels down and my high blood pressure down is also something. And then especially there's one part that I like to share is gathering family and friends, but also laughter is the best medicine and the best therapy in life of being healthy.
Like when we had a representative running for office, they come to your house, they say, oh, what can we do to make things better? I said, first thing, priority, Kupuna is first thing, and funding.
The challenges I did face as getting older is, of course, knowing that I had pre-diabetic and then high blood pressure, but that all started even when just working. But after I had bad arthritis in both of my knees, and that was a big challenge because it was very painful, and it had to make me stop hula for a while. And then finally I got in, even during COVID, they called me and said, if you're ready for surgery, we're ready to do it. So I had both knees done at the same time, but they're both partial, which still gave me a quality of life. So I got back to hula after that, after all my therapy sessions and everything. So that was my biggest challenge, was being away from hula. And then after the surgery and I'm now post-op 2 years now. It's getting back to walking more. So that's another challenge because now that we're retired, we just feel, oh, let's just stay in bed a little longer. And before you know it, we don't even know what time it is. So that's the biggest challenge, is waking up and getting ready to go walk. But other than that, it's still a good thing, you know.
Let me see, my wife and my mother had the same primary caregiver. And after my wife passed, he went into semi-retirement. And my mom really, I mean, she really loved her doctor. Yeah, and me too, he was a great guy. He went into retirement, so we had to go search, and Kaiser's great. I mean, you know, the online thing, I just went and I showed her, here, Mom. She goes, who's that? I said, this is the list of doctors that you can choose from. So, you know, I went down and I read their story, and she goes, oh, I think I like that one. Yeah. So we got her a new doctor. But when COVID hit, yeah, her expertise was needed in a different department. So, you know, sadly she had to, because, you know, she's a really, really great doctor, and Mom was really upset, not upset, but disappointed, yeah, because she just was getting the Hawaiian word ma'a. She was getting used to this doctor, and then we got to get a new one. So here's the list again, Mom. Because of COVID, again, we got to do the phone call or video call appointments, which is, you know, I'm even like that. I'm more personal type. I don't like to text, or, you know, if anything, I'd rather talk to you on the phone, but I'd rather see you face to face. And I believe Mom and that generation are from the generation when you shake their hand, yeah, it settles the deal, kind of thing.
He's 91, and if it's something that he wants to eat, he loves coconut. He loves coconut, Napoleon, bakery, coconut turnovers. I buy them because I let him eat, because I want him to enjoy it, you know. And it's not all the time, but there's times where I'll just come with his little decaf coffee and say, Dad, look, I get you a coconut cake, because he likes that, yeah? And he'll sit down and his eyes just brighten up. I want him to feel like he can still live, you know what I mean? He can still enjoy life, and he does. But I feel bad sometimes, because when I go to work, he'll sit on his chair, put his feet up on it. We buy all kind of different recliners, and he puts his feet up on the chair and just lie back and watch TV a little while, and then he's thinking, okay, you know, it's things that he needs to do. You know, I want him, Dad, I'll go take you to a daycare, or you can, you know, I don't like, you don't want, yeah. So I'll take him for a ride around the island on a Saturday, and, you know, maybe tell him, oh, we're gonna go holo holo, and then, you know, so he recognizes all the different new buildings, or the rail and stuff like that. Yeah, but to me, that's what it is to for him living healthy. It's not only just what he eats, but just to be able to eat what he wants to at times.
It did, and I think it did for a lot more, everybody, I think it did. It's mainly that it kept us at home and isolated away from family and friends. I mean, we could see family, but we had to make sure that we were safe to visit each other, and nobody, you know, was carrying a bug or anything like that, because at first you say you're sick, but you don't know if it's maybe just the flu, maybe it's just a cold you're gonna get. So it really isolated a lot of us. I mean, we could walk out in our yards and do things, but still, we had to stay home, except for going shopping and, you know, doing doctor visits and stuff like that. But even that was hard, because we had to do it on on like a Zoom call, you know, to see our doctor, as long as it wasn't anything of emergency. But other than that, I think it gave us something to really think about. And I think it was mainly to say, we have to care for each other. We have to care and respect and also be mindful of everybody else around us, not only our family members, community people, you know, our friends. You know, when we take things for granted and then we can't do it anymore, you know, we really have to think about that. But me being mindful of other people, I think is what it is too. That was good, you know, that we had to think about other people's health, their well-being, you know, especially for the elderly, you know, for the Kupunas out there. I mean, I'm not Kupuna, but anyone older than I am, we really had to think about them, you know.
Dr. Lawler, she's the best doctor that without her I won't be here because she's one awesome doctor.
Kula kept me busy. I had my calendar that has so many activities that they kept us busy in, and that's why I think it kept us with our minds going. It kept us with our health going. They put out so much for us, and they were always there to make sure that we were all in good health and in good mind. And it's, wow, I might start crying again. They're such a joy. God gave us the best leaders in this community. They really did. And I give back as much as I can to them if I have to. But yeah, they kept us all alive in good health, kept us with food coming into our homes, everything they did for us. And whoever they got it all from, God bless them all.
Thank you. Doctors, nurses. You know, after going, not just with my wife, but with my dad, yeah. And seeing people with, you know, I mean, I met nurses from, I got a friend from Delaware that helped take care of my dad, my wife, New York, you know, these traveling nurses. Seeing them come and assist my dad, my wife, yeah, with such love and care.
We would like to mahalo our community families, partners, and friends of Papakolea who have been a part of our journey. We look forward to the victories ahead for our Hawaiian homestead community. Me ke aloha, the Kula crew.
Okay. Mahalo, everybody. And I want to give a huge mahalo to Kula and to the Kupuna and caregivers that shared their stories with us. It takes a lot of courage to be vulnerable about your health and the health of those that you love. And I really want to honor that vulnerability that they showed sharing these stories with me and with us. All of these people are in the really capable and loving hands of the Kupuna Care Coordination Network at Kula. And most of Kula's staff were born and raised in the communities of Papakolea, Kalavahina, and Cavallo themselves, which is amazing to see how much work and effort they put back into their community, making sure that it grows and thrives for residents across the lifespan. I also really want to thank Mahelani Austin, who is the program coordinator for the Kupuna in Kula. She really made this video possible. And I want to thank Kawai Conrao, who was all the editing talent behind this video that made them come to life. That's a really big skill, and it was just beautiful. So next up, we're going to hear from CJ Johnson. He calls himself a storyteller and bridge builder. His official title is Product and Member Engagement Manager at Aloha Care. He works with community leaders and service providers to help Aloha Care better understand and address persistent barriers to health and healthcare for their members who are Medicaid and Medicare recipients across Hawaii. His goal is to build community bridges and help Aloha Care tell its story and weave a shared story of good health for Hawaii. So mahalo, CJ, for being here with us today, and I'll let you take it away.
Awesome, thank you so much. Yeah, this is really amazing. So if you're thinking that I look familiar, I spent like a year and a half, like 5 times a day doing vaccine outreach and telling people what mRNA is and why they shouldn't be afraid of emergency use authorizations, and was very exposed and had a very canned presentation that I did a lot. And when I was asked to do this, it's such a big topic. The idea of the need for advocacy, what advocacy even means, and that I thought for a long time about what I wanted to present and what I wanted to prepare, and ultimately I didn't prepare anything. I really wanted to just come into the room and see where folks were at and see where we were. You can't leave yet, you have to come back up here because I have some questions for you. Okay. But I wanted to leave it really open-ended because I know it's it's freezing in here and it's Saturday morning, and probably the last thing anybody wants to do after seeing something that beautiful and that cool is hear me talk by myself for 40 minutes. So I want to have a conversation, and I want to hear kind of what everybody else's experience it is with advocacy, and do you consider yourself advocates, and what do we even mean when we talk about advocating for a population, and what does that relationship look like between plans and between agencies and between providers and the populations that serve. And I wanted to kind of bridge that. I think we're doing the tech thing right now, but I want to grab Michaela when she's available and ask for a little bit of background on this project, because I'm really interested in how it came together and how and what the intent is, and whether there's opportunities to do other kinds of things. So if you are available to answer some questions, do you want to say that? So, I wanted to, this is the transition, right? I wanted to know, like, how did this emerge? How did this project come together? How did the idea to do this sort of video voice happen?
So I'm with the Department of Geriatric Medicine, and we sponsor this track every single year. And one of the things that Dr. Aida Wen, who will be here for our 3rd session today, always says is that geriatric practice is a team practice. Right? It's not just a physician who delivers care. There are a lot of people that need to be involved in geriatric care in order for it to be truly effective. So when we get our planning committee together every year, we try to have people from a lot of different entities. We have healthcare providers, we have health insurers, we have community-based organizations. So this year, Maha Austin was on our planning committee, and when she was talking about the challenges that they were having in communities and how they're overcoming it, it became really apparent through this and through other projects that we've been doing. So if you're here for session 2, we have some community-based organizations speaking as well. But that community-based organizations are a really integral part of the workforce themselves. They deliver a lot of care and bridge a lot of gaps. So our idea for the entire overall session was that we wanted to bring these Kūpuna Stories back to the center and establish CEOs as a really integral part of that healthcare landscape, bring attention to what they do on a daily basis for their communities, and talk about the power of communities. Communities know their problems and they know how to overcome them. They're the ones that are truly committed to making sure that they thrive. And they hold a lot of knowledge. They hold a lot of cultural knowledge, they hold a lot of health knowledge, and those should be optimized. We should use those to better the health of our people and our kupuna.
So the actual like nuts and bolts of the video, of this being a video project, where did that come from specifically? What was the funding structure? Who came up with the idea? Who steered it? Who pushed it forward?
Maha told us, why don't we do video stories? I guess they do them at Kula a little bit. So the first part of that was a video that they did at the beginning. So she said, let me see if there are some kupuna that would be willing to share their stories first. And when she got some interest on board from people, we'd originally thought that maybe we would bring them in and do a panel, but that was really overwhelming, having them come and speak to a lot of people, coordinating them here. It felt like a lot. So she said, we've done these story projects before, why don't we do that? So she got some buy-in. Me and her went back and forth on an interview guide, just put together some questions that we thought were general enough. And then I went in person to collect the stories. because I felt that was culturally appropriate and personal. You're really asking people to share a lot of themselves and be very vulnerable, and that's hard to do through a screen. So I went myself and I collected the stories, and there were some tricky cultural protocol issues with that with COVID, where I felt like we couldn't share a meal, with masks. I wasn't sure if they were comfortable with that. So I gave them mahalo gift cards instead. And I know it's interesting. COVID has created some boundaries of the way that we just relate to people that has been really challenging. But I really want to thank the people that shared their stories with us. It was really a gift.
And who did the editing? Like who actually put it together?
Kūpuna did, who is one of the staff over there that does some volunteer work with them, and she made it come to life. I mean, the editing and the pictures and the story that she wove with it, it's really beautiful.
How do you, I saw that someone asked in the chat, is this available to watch or to share offline in other ways? Is that on YouTube or anything?
It is on YouTube. I think it's going to be linked to the conference website eventually, but I can make the YouTube link public through the Department of Geriatric Medicine website as well.
But what do you hope that people take away from it? Like what's your goal if people watch that?
I think it depends on what lens of healthcare you're coming from. For providers who don't get a lot of time to hear the stories, sometimes I want them to really connect with those stories and the human aspect of what that is. For funders, I really want them to think about how community-based organizations are a really integral role of our healthcare system. And it's really hard to fund them sometimes when you have all of these small grants coming from different organizations. You have competing priorities. And it's really hard to go through subcontracts, and you have to do so much paperwork for money. So how can we fund them easier, as valuable entities, and just hearing the voices of communities as valuable and powerful.
Do you envision other uses for this, like other applications for the like how will it be shared or propagated in other contexts, or was it made specifically for this?
It was made specifically for this, but it will be handed over to Kula to do what they want with it, and we'll integrate it into websites too. Yeah.
What did you learn about the process of putting it together? Like if someone else was wanting to do a video voice or stories like this, what lessons learned would you want to make sure they were able to take from your experience?
There's a lot of different pieces that go into it, right? It takes a lot of planning, a lot of time to do something like this, and it benefited me to have people with different skill sets as part of it. I'm not an editing software person. I was able to cut them and put them together basic, but having somebody that is able to do that is really important for them to really be honored correctly in this format. And I think that there is a certain, when you're asking somebody to be vulnerable with you like this, you need to be careful as well to minimize harm and risk to them, right? So there needs to be some consideration and respect going into collecting stories in general.
I think you guys are the ones that make the session advocates, the name Advocacy. So what do you view as the relationship between this sort of storytelling and advocacy? What does advocacy mean to you in this context?
Advocacy, I guess, in here was letting people speak for themselves, right? So many times we have individuals that never have the power to sit in a room like this and share their stories and what is important to them. So allowing them to speak for themselves on whatever they wanted to. We had an interview guide, but I went in there very loose as well and let them speak about what was important to them. So that's
I find a lot of times that what we talk about, so most of my job, so I was starting to tell a little bit about my bio before we got into the session formally, but I've been in law care for about 4 or 5 months. Before that, I was at the Department of Health for some time. My career has mostly been at hospitals, nonprofit, Department of Health. I mostly worked in community engagement, community outreach. And I think it is challenging sometimes to bridge those gaps between the actual authentic community experience, especially communities that are disproportionately impacted by historic barriers and exclusion and inequities. And I think you nailed a lot of the challenges and a lot of the things that we talk about in terms of why, and a lot of it, I think as highfalutin as we can get, a lot of it does come down to funding and how we can structure agreements that in such a way that the people who are providing us this information, providing insight and expertise into their communities are actually benefiting from that and not being expected to do it out of the kindness of their hearts, right? So my role during the COVID pandemic, so my background is chronic disease prevention, health promotion, and I'm more on the built environment side of things. But I got involved in the COVID pandemic because I was at the Department of Health, and everybody that was at the Department of Health got involved with the COVID pandemic, no matter where they were or what their job title was. And the role that I filled was doing this outreach and working with community partners. And what we quickly realized, and what we quickly came to understand, and I think obviously we all know this anyways, during the pandemic, I think a lot of our agencies and a lot of our institutions that were already kind of underfunded and struggling with workload and struggling with personnel, right? We're all in a crisis with personnel right now. We weren't teed up. We weren't ready for something as catastrophic as a global pandemic. And as a result of that, we were caught flat-footed. And as a result of that, I think there was a lot of populations and a lot of community leaders that stood up and did really, really amazing community work. And I think this is a really good example of that. But when I was asked in my role at the Department of Health to kind of be the connection for those community efforts, especially with our priority populations, our health equity populations, there was a tendency from our federal partners, like our CDC Foundation partners and other organizations, to try to parachute in and solve problems and just say, hey, we're here, we have money, we have expertise, what can we do? Or to just come in and set up programs or put up a tent in a neighborhood. And what anybody who's done this work knows is that people in communities that have been underserved and have been chronically exploited don't wait for help. They don't wait for the government to show up. They don't wait for the CDC Foundation deploys to come. So it was really incumbent on us to listen and identify those partners that were already doing the work. And rather than coming in and reinventing work, rather than coming in and creating things from scratch, figure out how we can integrate them, right? And so what ends up happening is that we're talking about like June, July, August of 2020. It was very clear that the Department of Health and a lot of our systemic partners were not up to the challenge and were not responding to those needs well. And it was manifesting in terms of disease rate, it was infection rate, right? And a lot of these disparities are the same disparities that we know from chronic disease, because a lot of them are based in social determinants and based in geographic, language, cultural barriers to access to healthy living and to healthcare. And so what we quickly realized was that there was a ton of organizations that had just stood up either as volunteers or that were social services organizations in communities that were doing critical work, and they were doing it self-taught. And they were doing it without any coordination from state agencies or from the Fed or whatever. And this is like just volunteer groups that were serving migration population and Hawai'i population, doing rent assistance webinars, doing food distribution events, doing PPE drives, translating CDC documents into their language, or creating new graphics using existing documentation. And they didn't wait for us again, right? They were doing this incredible work. And I think it took the Department of Health, and I think it took the state, I think it took a lot of folks a while to figure out how to, and I would say actually, I don't think that we have completely answered these questions. I think we figured out like what is the relationship and what is a sustainable way to engage that relationship between these really critical community resources and our health systems and our public health systems. Because we're still in a situation now where a lot of that work is being done under the guise of like community investments or philanthropic grants, as opposed to technical assistance and as opposed to expertise, right? We don't think of expertise in language and cultural knowledge and understanding of social infrastructure the way we think of marketing expertise, or the way we think of practice consultation, or a lot of these things that we all spend a lot of money on technical assistance or these sort of professional capacity building, but we are reluctant, or we don't have the language or the infrastructure to think why is it, and the example that I use a lot with COVID, right, is I could engage someone off the street who speaks Marshallese and has no background, no grounding in health, and chronic disease, and public health, and vaccines. I could spend a week with that. I did this frequently for a year and a half, and engage them on everything that they need to know to be a health ambassador, to be a really effective health ambassador, and they'll be a really effective community health ambassador based on their pre-existing cultural knowledge, their language skills, and their understanding of their social infrastructure. Whereas we had people, again, being deployed, national people that were being deployed by a CDC foundation or other national partners, or people that didn't have those backgrounds, that had advanced degrees and a ton of clinical experience, or a ton of theoretical experience or process experience. I can't teach them Marshallese in a week. I can teach them about the social infrastructure of a community in a week. And I think that it's really, so once you acknowledge that, right, that's really obvious when you say it that way, like that's really clear. But then when we look at like, as insurance systems and as health systems and as community organization, or as nonprofits and NGOs, is that reflected in what we're paying people? Is that reflected in what value we're assigning to that work? And for the most part, we're assigning the people, we're calling the people who have cultural knowledge and language skills and that sort of social infrastructure knowledge, community health workers, and they're worth one amount. And we pay people that have advanced degrees in public health and some of these clinical fields 2, 3, 4, 5 times more than we're paying both the individuals and the institutions, the organizations, the CBOs that they work for. And there's huge disparities. And I think that it's not nefarious necessarily. I think, having been in an agency position, having been in that situation, I know that agencies are understaffed, and that when you have $1 million, literally $1 million in federal funding, you have to spend quickly. It's much easier to write one contract and get that one contract out to a very professionalized organization that that knows how you like your invoices. I think that's the easy way to spend money, because there's one of you doing 4 jobs. But I also know that when you do that, and when you aren't kind of thought, if your priority in your contracting and your spending and your investing is people that are good at filling out government reports, as opposed to people that have the experience that you need, people have that cultural knowledge, it's going to continue to manifest as these organizations are not invested in to professionalize. If the reason that they're struggling with reporting, and the reason that they're struggling with reimbursement, and the reason that they're struggling with these partnerships is because they don't have enough money to hire people. They don't have, and the way that we engage them isn't through contracts, isn't through longer term agreements, it's through these grants that are, feast or famine. There's huge amounts of money right now that are circulating, but they have these runways that are like, you have $10 million in 6 months to spend it, and then we don't know what to tell you after that. How do you develop a workforce? How do you develop a community health workforce that you're paying them $1 more than they're making retail, and you don't know if you're going to be able to keep them working after this particular short-term grant expires in 6 months? And so I think that's something at the Department of Health. When I was there, we were really struggling with, and we were really trying to think through, can we change that? What is the path towards acknowledging and appropriately compensating the lived experience, the cultural knowledge, and the language knowledge as technical experience, technical expertise, and capacity. And I think at Aloha Care, we're also having those conversations, is trying to figure out how to quantify that and how to engage that. So I feel like I'm ranting a lot now. I wanted to open this up as sort of a conversation, see where everybody else. Yeah, thank you. I just sort of got it going, but thank you, Michaela. I wonder what everybody else has experienced with this transition. I think the reason that this is really timely and really time sensitive, in addition to the fact that we are kind of in a workforce crisis right now, is that we do have a kind of a once in a lifetime opportunity, right? Because we do have a lot of people that didn't come from public health, didn't come from healthcare systems at all, that just were, maybe they lost a job in a different industry, but they happen to have the language skills and cultural knowledge that made them really valuable in this moment. And now there's this opportunity to either we're going to lose them, right? Like if we don't figure out how to keep this, how to engage this, change our systems, change our health systems, our healthcare systems to respect that value, it's going to be really hard, because it's been my experience, I know probably most of your experience as well, that if we don't honor this commitment and we don't keep the people that we've invited into the space and we've given some sort of tentative contracts and tentative grants, if we don't figure out a way to keep them engaged, we're going to lose them. They're going to go back to whatever they're doing before, and we will be poorer for it. And our health equity disparities are going to be entrenched. And we will have lost ground, right? Because we will have broken the trust of a lot of people who entered into contact tracer programs or community health worker programs with the promise that there's like a brighter future that honors that value. And if we don't actually turn that into, operational change within our institutions, we're going to be in really big trouble. I wonder if anybody, I don't have any program prepared, I'm just kind of riffing here, but I wonder if people have experience or thoughts on where we're at with community health work and where we're at with cultural knowledge and language skills in our practices, if we have any thoughts. If there's anything in the chat.
Yeah, so Dr. Wynn says, this is a very powerful concept. Putting resources into the community and CBO can be more nimble and more effective. How can we convince more payers, healthcare systems, and DOH to pay for those community advocates? Is anybody, or are you doing studies and collecting data about these benefits?
We are, there's a lot going on. I hate to get, I know there's another session specifically about the CBOs, and I don't want to step on anybody's toes, so maybe I could tease that some of my colleagues and dear friends are going to be talking a little bit more about how to make that tangible. Certainly there's a lot of information out there. There's a lot of studies about the impactfulness of CBOs and their cost effectiveness, and the question, the real question of how can we convince more payers? Yeah, I mean, it's going to take dollars and data and for people to see it. But I think that it's going to have to come. I mean, again, what I said earlier, right? It's like we select right now for how good our contract partners and our vendors are at filling out our paperwork and how good they are at doing our reports, our invoices the way they like it, and if they have the tolerance organizationally for reimbursement structures that are kind of onerous, you have to spend a lot out of pocket and get reimbursed for it. And I think there's little things that we can do. I mean, I think it's been I think the most obvious outcome, right, to the question of like what's the benefit or how we prove the benefit. We saw tremendous benefit in the vaccine and COVID rates, right? So when the pandemic started in the first year in 2020, the disparities, especially the disparities with Pacific Islander population, were staggering. I mean, we had, they were like 45% of the population and 25, 30% of the cases. And then in addition to that, right, you have all these social determinants and chronic diseases and pre-existing conditions that were this compound inequity, right? So they have social disparities that are making them more likely to be exposed to COVID, which is like, workforce stuff and household stuff and language barriers to good information. And so they're more likely to get sick. And then also because of a lot of the same social disparities, they're more likely to have chronic diseases underlying. They're going to make them get more sick when they get sick. So we had a horrible disparity. And you can see pretty clearly that when the strategy changed, right, the initial COVID strategy in 2020 and in the first half of 2021, so the first 6 months of the vaccine campaign, everybody remembers this, right? We were really focused on pods, remember pods, and like just getting as many people in and out and like focusing on these high volume, centralized places where we could just push people through. And during that 6 months, the disparities in vaccine rate and in disease rate were staggering with our Pacific Islander population, especially. Probably with others as well, but we didn't have the disaggregated data, which is something that one of my colleagues are really knowledgeable about. But we saw that was really bad. Once the strategy shifted, and I credit a lot, and probably organizations that you all know work with, but We Are Oceania was a huge pioneer in a lot of this work. They did really amazing stuff and worked with the FQHCs, and in particular with Kupuna, to say, what if instead of trying to direct our Kupuna and our members to these big events that are, kind of daunting and overwhelming and inhospitable and maybe not linguistically accessible or even like transportation accessible, what if you just gave us a couple of 100 doses and we set up in the parking lot of St. Elizabeth's and we invest in you to just do outreach through churches and try to get people to come down and answer the questions and we'll give doses. That strategy ended up being really, really transformative. And now it's so intuitive. Like now that's all we do, right? I mean, for a couple of years now, it's been, the goal has been pointing the hose at the fire rather than like advertising to the fire, hey, come here and get extinguished, right? And that's been really transformative. And I think that in and of itself is really evident that that's a model for care that is effective and just really, really leveraging these community partners. And again, considering them as experts, considering whether or not they have the necessary public health grounding or epidemiological grounding, just like they have an expertise that's every bit as valuable. And in a lot of cases, when we're trying to be persuasive and trying to be inclusive, more valuable So I think the disease rate changes, and you can see this when you go to the Department of Health's vaccine rate and disease rate, and it is disaggregated by Native Hawaiian Pacific Islander. And there was a huge shift in the disparity. Of course, there's still disparities, but they were really dramatic with Pacific Islanders once the strategy shifted from, hey, come to our football stadium, to, hey, we're gonna come and provide vaccine to local organizations. I would say that the challenge with that is that I still don't know. I think that they're in a better position now. I'm not there anymore, but it was challenging to figure out how to pay people to do that, how to pay the community organizations to be there, to provide music and make a comfortable environment and have hand holders for the Kupuna and provide for the rides and stuff. I think that was really challenging to the norms that health departments and emergency managers were used to. And so they came up with some ad hoc solutions to it, but I don't think that there's like, that was demonstrable in its impact. I mean, you can see that the numbers were better, right? But I don't know that we've done a great job of institutionalizing those changes. I think a lot of it was still very ad hoc. Now there's like, okay, well, how do we make these partners long term? I think that one of the big wins too was contact tracing. Folks are probably familiar with the Department of Health had a stable of Native Hawaiian, particularly Pacific Islander contact tracers, who were, again, people that did not come from health backgrounds. They were people that were maybe unemployed or underemployed and signed up for the UH program that the DOH paid for. And then they went through that training and they became contact tracers. That ended up being wildly transformative, right? Because if you have somebody calling that sounds like me, and you're someone or you're Marshallese, and they call you and they want to know everybody you've talked to in the last 2 weeks, you're not as likely to answer as you are if it's someone that speaks your language. It sounds like they're from your neighborhood, right? You're going to answer. And so that was hugely transformative. That was really valuable. And then once you have this workforce, like 30 people at its height, they're also doing wraparound. They're doing housing referrals, they're doing food referrals, they're doing a ton of extra work. And so you have this, that is a public health workforce. You've just created a public health workforce of 30 people. It's, as I understand it, and maybe somebody knows more recently than I do, maybe Rose or somebody, it's in the process of being decommissioned, right? That contact tracing team. I don't know that there's, a lot of them are finding jobs, a lot of them are on their own volition, finding other opportunities in public health, but there hasn't been like a concerted effort to like keep that integrated into our public health system, our state public health system. And I think it's a loss, right? We really ought to be looking at how we can keep those people engaged.
There's a microphone over here.
Oh, yeah,
if you'd
please.
like to come pose your question. Okay, we have a guest in the audience asking a question right now.
Got it?
I got you.
Okay. This isn't so much of a question, but I'm glad you mentioned the fact that, these contact tracers that were very specifically sought out and brought on board are now being decommissioned. I teach community health workers, and I think this was some lessons for Department of Health. And at first they were like, we said, we have all these community health workers being trained and that we've trained. We have a whole network. And they were like, no, we want people with bachelor's degrees. And it's like, okay, but they know languages, they know their neighborhoods, they know their communities, they have basic public health knowledge. And if you just gave them that training, they'd be so good to go. Well, it was like, no, we know how we're going to do it. And of course, there was that huge shift in Department of Health, which I think maybe helped. But the next move was we heard, instructors were asked by Department of Health, and I don't mean to come down so hard on Department of Health, but again, think of it as lessons learned. And they said, do you know, people who have gotten their CHW certificate who speak, Marshallese or Turkeys? And we're like, yeah. And they were like, give us their number. We want to hire them. I was like, wait, they're already working. Oh yeah, but we can hire them. And it's like, no, they're already working, you know? And I think one thing to keep in mind for the future, they were working with FQHCs. They were working in clinics. And the more appropriate move would have been to partner with the FQHCs, with the clinics, because these people had jobs that they had benefits that were, you know, yeah, they're grant funded and they go grant term to grant term or whatever. But getting the Department of Health to get in that public health mode of, you know, we're partners here. And especially when it comes to infectious disease, because you don't want to pull people out of those jobs, especially from those communities, to more uncertain futures than they already have, when they have such an extremely valuable skill. And that is to be able to communicate with this population that was just not being served well because of those barriers. So that was my comment.
Yeah, I think that's always been a challenge. That was certainly something that we thought about a lot, and something I think about in Aloha Care a lot too, is to what extent is it valuable to recruit versus develop these partnerships, right? One of the things that I work on both at Aloha Care and kind of as a volunteer is transportation equity, which is to say the relationship between transportation systems and built environment and like transit and how it works and sidewalks and things like that, and people's access to healthy living and opportunity and all that. And I think, you know, let me approach this a different way. When we were doing COVID outreach for our priority populations, we were so high profile, I was so high profile that we were getting constantly from other, you know, agencies and other branches of DOH, hey, we are working on a lead paint campaign and we want to do a lead paint awareness, a youth lead paint awareness thing in Micronesian languages and cultures. How should we do that? How should we approach that? Which is where they were coming at us for advice. And I mean, the answer is money, first of all, right? Come with respect and come with money and with honoring that there are organizations that are doing this, but also like they're so busy, right? The organizations that the We Are Oceanians of the world, the Marshallese community organizations of Hawaii are so busy and they're so overwhelmed. And again, we have not, any of us really agency-wise have not like invested in their long-term capacity where they can meet some of this demand. And so it just becomes really transactional and really hard to manage these relationships transactionally when you're like, oh, do a thing for me, even if you do come with money, if you're not coming with like a long-term sustainability plan. And I think there is a really valid question of like, how much internal cultural capacity staffing do you want versus how much do you want to build up these community resources that do have, you know, how much do you want to invest in your full cares and your MCOs and your community orgs that do have as a core competency. Our core competency as an organization, as a CBO, is cultural knowledge. We know good communication channels. We know how to do social media in a way that reaches our communities. And it feels to me like that's like that. I think you're right? It's like, and FQHCs are a huge part of that too, obviously, right? It's a little bit different. It's the same idea, but it's like a geographic versus demographic lens. But there's both a challenge and an opportunity in trying to figure out that sort of spider web networking of like geography versus demography, because there's some orgs that have this very targeted demography but a really wide reach. And then there's the FQHCs end up being these really powerful geographic partners. And so I agree. I think we really have to be thoughtful about that capacity and figuring out ways to invest in them strategically and not just a lot. And there's a part of this that is a little bit tricky from the perspective of not necessarily the Department of Health, but from the plan perspective and the health system perspective is we can get tax credits and other kind of, you know, touchy-feely benefits from community investments. And so a lot of times when we invest in these community orgs, we invest in them as charities, we invest in them as 501(c)s, and it's a way that we can brag about how charitable we are and how invested in the community are. And that's great. We should be invested in the community. We should be giving back. We should be philanthropic. But I think it is really dangerous sometimes to regard this community expertise as charity, and it's like a community investment versus an expert in like, you know, because we don't pay people enough when we regard them. It's a nice to have, not a must have when we think about people as charitable investments or community investments rather than as technical assistance and technical expertise. So I hope that I think it requires a lot of patience again, because a lot of these orgs that we're working with are on runways right now. There's a cliff at the end and they don't know what they're going to be doing in December or 6 months from now because the funding that's been made available via the Fed especially. And I you know, you joked about picking on the DOH, and I'm certainly not trying to pick on the DOH, I work there as well, but I don't think it's anybody's fault. I think it's that, you know, all these institutions were gutted beforehand. You know, we were understaffed when I started before the pandemic, and then you know, at the federal level things are understaffed and gutted, and then you get this huge catastrophic problem, and you just push money down. You know, the Fed just pushes it down to the states, and then the states just push it down to the CBOs or the NGOs, and the NGOs push it down to the CBOs. And I think that's the thing that I worry about, is that it puts a lot of burden and a lot of conspicuous visibility onto these CBOs to do the work that, you know, the agencies should have the staff to do, with the capacity to do more of. And then it looks from the outside like, you know, to the extent that the work that we don't solve all the world's problems on the backs of CBOs, it looks like it's on them. It's not. It's that it just keeps getting pushed downstream, and that's really unfair. So figuring out fairer ways to engage with the CBOs, I think, would be really valuable. That's what I'm talking.
Does anybody on our online audience have any questions? You can drop them into the chat box and I'll read it off.
Oh yeah. Hey.
So I thank you first and foremost for sharing your memo and all of your service to the community over the last couple of years now through the pandemic. I guess I'm just recognizing there's a lot of different expertise in the room. Like some of us provide care, some of us are more program people, but in our different spaces of work, I'm guessing, like I'm wondering if you have thoughts on like common denominators or common signs of like how we really or how do you measure successful person-centered work? Or like what are some signs that we're really centering in on the patient and the woman?
You didn't do it on purpose, but you totally teed me up for a little promotion of Aloha Care. It is hard to measure, right? I mean, I think that the long-term measure is health, is reduction of disparities, right? So we want less disparities in population health outcomes. We want less disparities in chronic disease management and access to care. More broadly, if we talk about person-focused care, we want less person-focused care. We want less disparities in built environment and food access and civic engagement access in general, right? So I think that over the long haul, those are the things that you can measure. I was going to talk specifically, I was going to bring this up later, but one of the things that I'm really proud of about Aloha Care, and one of the things that I came to Aloha Care for, it was mentioned in the public Kula video, is some of the cultural health elements that they provide, right? So they support lomi massage, they promote Kula as a physical activity and a social health and social connectivity plan. So that's actually, those are actually, you may have heard, it was on the radio a little bit ago, but among the Aloha Care's value-added services that we're supporting now are Native Hawaiian healing programs. And those are programs that were developed via partnerships and via listening to projects like Kula, folks like Papa Kulea, Papa Olakahi, and really being intentional. I'm proud that we're a community affiliated plan, that we work through the FQHCs, and that allows us a little bit better of a listening position. But yeah, so you can look it up at alahacare.org. But we have a Kula value-added service, Ipono, which is the traditional Native Hawaiian healthy diet. It includes meals that are well balanced and prepared locally. We work with some of our FQHC partners on that. Lomi and Ho'oponopono. So again, those wouldn't have happened if we weren't engaged and listening to our community partners that are doing this work and finding success with it. So I think we're always in the process of trying to listen better and try to figure out what are the kinds of benefits, what are the kinds of support and services we can offer to our members that are more likely to keep them engaged with care and also keep them healthy and managing and preventing and managing chronic disease. So, from a plan perspective, right, it's utilization of those. It's one of the things is are we providing things that are valuable to people? one of the things that gets talked about a lot, again, from a transportation perspective, which is the other thing I do a lot, is what if we did bike share memberships for all of our members? Well, bike share is only available at like urban Honolulu, right? Like that's, and not even really in Kalihi. It's mostly just like confined in, on this side of the canal. So like that sounds great. And when if you're not listening or you're not connected, there certainly are plans where they go, yeah, let's do a bike share benefit. Like that's a really easy, I mean, people love proposing. And it's like, but that's not listening. Like ask and engage and listen to your population and see if they're going to use that. Would they use a bike repair benefit? That might work better. Like if you had something where people get a tune-up every year on their bike, that might be a little bit better benefit. So there's the difference in those kind of subtle things. Is like understanding what the barriers are and addressing those. I think the more your members are actually taking. If you put a benefit out there and nobody's using it, then you're not listening very well. But if you're committed to listening, and if you're committed to being out there and being better engaged with I look at it as my job in terms of engagement is provider. We have a provider engagement team, so that's not my main thing, but provider, community partner organizations and CBOs and direct member engagement, just listening to all of them and trying to formulate like how can we engage and compensate our CBO partners in a way that leads to them being able to help us serve our population better and be where they need to be and hear what we need to hear from them. Yeah, please.
Sorry, I'm from the big end. I work in primary care, and we're on the Big Island. And one of our biggest issues is location. We have a lot of isolated communities that don't have access to care. Are you guys doing any outreach for like flu clinics this year or anything like that? Or how do they get access to that kind of care? I mean, you may not have any experience with the Big Island, but people are far away. They're not going to be able to ride bikes. They're going to, so just wondering what your guys' maybe future plans are to get those kind of services out there to those people.
There might be FQHC people that can speak more specifically to that. Certainly, we don't do direct service. We coordinate with the FQHCs to support service. But I mean, I know that there are mobile vans and there's various mobile efforts that are going on because that is a huge challenge, right? It's that vastness, the geographic vastness of the area. So I'm sure I can find out, but the partners are the ones that are doing more of the direct, the clinics, the FQHCs are doing the direct mobile stuff. I know there was a lot of investment. That's the pandemic, right? That really, I think, saw a lot of investment. A lot of the CARES money or money and stuff ended up going to mobile, like buying a van so that you could do stuff on the side or stuff in the community. And there's again, and also to telemedicine and to telehealth and teleconnection and organizing. I think that's something we're probably all hopeful that we can continue to grow on. And this is super exciting to me. I hope that those of you that are watching remotely are having a good experience for it. I've done a couple of them, on the other side of a couple of them. I think it's great. I think speaking of advocacy, from an advocacy side, I think going forward as we look at like legislative opportunities for better support for care and for Medicaid, I hope that our legislators don't get rid of that, because that was such a huge thing in terms of making it easy for our rural health partners and their rural health members to testify and to participate actively in the legislative process and get better outcomes for them. Because 2 years ago, when people were Hawai'i Island based and they wanted to testify before the ledge, they flew in, and now they can do it really, really easy. So I think on one hand, we're all in this big hurry to get back to normal and get back to in person. But I think for rural health, and I think for inclusion of people with disabilities and caregivers who may not have schedule flexibility to go testify in person, making sure that we're figuring out how to do hybrid engagement in an ongoing way. I hope that hybrid is here to stay, because I think it's really transformative. I think it's a really good opportunity. As much as people complain about being stuck in front of Zoom all day, the fact that like every auntie and Hilo knows how to Zoom now, right? That's I think a really big thing that we want to keep alive.
Okay, I think we have time for another one. Dr. Wen asks, do you think promoting telehealth increases or reduces health disparities?
I think that it's probably, so we just started to get there. There's a lot of people that are experts on that. I think I know that the counter argument is like, oh, well, not everybody has a computer and not everybody has a phone. And those things are certainly true. I don't think that they're like a panacea that gets rid of all of it. But it is really remarkable and this is my experience as someone who spent like I said, like 18 months to 2 years on Zoom, like for 14 hours a day doing, being translated to Marshallese and being translated to Ilocano and working with community-based organizations and CHWs and trying to get word out there. My ability, if not to connect directly to populations, my ability to coordinate with CHWs and coordinate with other people that are doing care and make sure that we're getting information out in a timely way. I used to, for an example, a lot like when the Johnson & Johnson pause happened, right, back in 2021, it became really urgent that like we need to have strategies for getting information out in language culturally quickly. And so we invested a lot in workflows that went from CDC to the Department of Health or NHS or whatever to these community partners and out. I think that the fact that not everybody, but a lot of people learned Zoom and again, like, and we already, I think one of the things that people maybe misunderstand or don't work directly with immigrant populations a lot is that like Facebook Live is a huge tool for immigrant populations, even seniors who maybe not the most tech savvy people in the world. When you're in the country that's different from where a lot of your family lives or where you feel a lot of cultural connection, Facebook was a huge tool for getting all, we would see like one of the big examples, like We Are Oceania would do these island hopper Facebook Live events, and you could look at any given time and there was like 1,500, 2,000 people watching, and they're speaking Pompeian or Chuukese, and they have all these viewers in real time. Like I would kill to have 1,500 people on an English language DOH webinar, and they were getting that routinely. Or when the Marshallese Consulate and Marshallese Community Organization in Hawaii would do a Zoom town hall, they'd get 10,000 people from all over the world watching it. And so I think there are certainly barriers to being online and to Zoom and to Facebook Live, but it is a really, really, really powerful tool. And it's, Zoom's pretty user-friendly, with even just a basic connection. And so I think to me, it seems really obvious, just having spent a lot of time doing outreach specifically to low English proficiency, geographically remote populations, that it was a huge net positive. It's a really important tool.
Okay, well, I think that, go ahead. We have one more.
Sorry, I know we're running low on time, but I just had one concluding question that I wanted to ask. So I'm a registered nurse. I work in a primary care clinic affiliated with a large health system. So we're oftentimes looking at how to partner with community-based organizations. So my question is the big trigger right now is population health, and the state of Hawaii has a growing population of Kupuna, right? It's like one of our largest populations, and so we're all sitting in this room today because we're interested in Kupuna care, and so population health oftentimes is driven by these community-based organizations, right? They're the people who are boots on the ground, they know what their communities need. How would you recommend, based on Aloha Care's strategies that you use, for us to start getting involved with these community-based organizations? So like larger health systems, how do we get our foot in the door with these community-based organizations and partner with them to offer population health-based services? And you don't have to give me your secret ingredient in Aloha Care. We don't want to steal your strategies, but I'm just curious. I'm like, how did you guys originally establish those relationships with those community-based organizations to grow the benefits that you're now providing?
First of all, I don't we have trade secrets, but by and large, I would feel terrible if I regarded community engagement as a secret. Like I really want everybody to benefit from what we do in that regard. I think that's immoral otherwise. I'm going to punt that one to the next session because that's what the next session is about. And my great colleague May Rose is sitting up, and then I know they're going to be having a second. They've done really amazing work. I think my short answer on that is I spent a lot of time when I was at DOH. I spent a lot of time just trying to hear from our partners who was doing good work. Just like listening, like who's out there without any support, without any financial backing, who's doing the work, and then identifying them and just bringing them in. In the first place, it was like, just come to this meeting. We got a meeting every 2 weeks. Just come and we can share. We can make sure you get translated information on time, and you can help us understand like how to translate it well. And just having a meeting, and then it was a little bit of funding. And so I basically through the Department of Health helped to build a network of partners that we knew were effective, that we knew had a good reach. And I didn't steal them. The DOH still works with them too, but when I moved to Aloha Care, I just reached out to all of them and said, would you also like to contract with us to help us with, some of these challenges, help us. Our challenges, right, are we want to keep our members healthy, we want to keep them engaged with their primary care, like healthy, engaged members are the kind of members, and that's what we want. So my goal is that that it's easy to find. I think the hi-fi and the work that Rose is doing, that she's going to talk about here in a little bit, is really, really valuable to that. There's a couple of sort of larger health organizations that have really done a good job of receiving some of the bigger funding and putting and organized the created infrastructure and organization for some of these orgs. And that's my hope is that in the years to come, wherever it lives, whether it's hi-fi or someplace else, that this is a resource that people can just go like one stop and say like, hey, we need to work with this, because it's hard not just on you guys, but it's hard on the organizations, right? Like one of the things that was really funny, sad to me was when I left DOH and went to Aloha Care and started working with DHS more closely. I met my counterparts at DHS that I never met and never spoke to at DOH. So I was a DOH and this person was a DHS, and we were contracting the same community owners, the same CBOs, and I'd never heard of her and I'd never met her. And that to me was a huge missed opportunity at the agency side and on the system side. So how can the systems, the agencies and the large health systems be coordinated? What is that clearinghouse, or what is that infrastructure that can make it so that your one person CBO shop doesn't have reporting conflicts and 16 different invoice formats and all these different deadlines and 2 reports due on the same day and 2 RFPs due on the same day, and the RFP, how can we make it easy on them administratively? And I think that those large NGOs, those bigger NGOs could play a really important role in that. So I know we're over.
No, I think we have one more question that's going on.
Hey.
I don't need a mic. I'm just curious, I'm in the Big Island, and what you share, you do that here. You do the same thing?
Say again?
Do you do work on the Big Island?
I am from Aloha.
So you was just sharing that you needed with the community based on. Is there somebody that doing the same thing on the Big Island?
So most of the organizations, so I work with two categories of organization. One is the FQHCs, right? The community or health organizations, and they're geographic, and obviously we have CHC presence on Hawai'i and we coordinate it. The other are demographically based. So it's our Filipino outreach groups, it's our Marshallese outreach groups, it's our Micronesian outreach groups. So we have groups that the way that we developed contracts with them was that their obligation was to have to be our sort of eyes and ears demographically. So we're contracting with We Are Oceania, then it's on them, it's their responsibility to do you have a local partner that's working on Hawaii Island? And the assumption is that they are. It can be very, and this is probably not news to anybody, it can be very tricky. You can either err on the side of micromanaging existing relationships and infrastructure or being Oahu-centric, and it's always one or the other. And so you just have to be really, it's a dance, and we're always trying to do it right. We have staff, Aloha Care has staff on Hawaii Island. We work really closely. We fund FQHCs to do community outreach work and to coordinate, but it's a work in progress for sure. But
okay.
Yeah. I'm just curious. Contact to be
I got cards for anybody that wants cards. Or C Johnson at aloha.care.org if you want to follow up and work on stuff together. That'd be great.
Community engagement is all about respect and building relationships. So if you're interested in hearing more about it, please join us for session 2. And that is it. Please join me in thanking CJ and Kula Nona Po'e Hawai'i for our session 1. And we hope to see you again.